Hi everyone, welcome back to my YouTube channel. On November 1st of 2022, CMS issued Medicare Physician Fee Schedule Final Rule for calendar year 2023. Since it's quite lengthy, I'm creating another part 2 video to cover the key takeaways from this final rule. Let's get started. On November 1st of 2022, the Centers for Medicare and Medicaid Services, or CMS, issued a final rule that includes updates and policy changes for Medicare payments under the Physician Fee Schedule or PFS and other Medicare Part B issues effective on or after January 1st of 2023. The calendar year 2023 Physician Fee Schedule Final Rule is one of several rules that reflect a broader administration-wide strategy to create a more equitable healthcare system that results in better accessibility, quality, affordability, and innovation. Background on the Physician Fee Schedule. Since 1992, Medicare payment has been made under the Physician Fee Schedule for the services of physicians and other billing professionals. Physician services paid under the Physician Fee Schedule are furnished in various settings, including physician offices, hospitals, ambulatory surgical centers, skilled nursing facilities, and other post-acute care settings, hospices, outpatient dialysis facilities, clinical laboratories, and beneficiaries' homes. Payment is also made to several types of suppliers for technical services, most often in settings for which no institutional payment is made. For most services furnished in a physician's office, Medicare makes payment to physicians and other professionals at a single rate based on the full range of resources involved in furnishing the service. In contrast, physician fee schedule rates paid to physicians and other billing practitioners in facility settings such as a hospital outpatient department or an ambulatory surgical center reflect only the portion of the resources typically incurred by the practitioner in the course of furnishing the service. For many diagnostic tests and a limited number of other services, under the physician fee schedule, separate payment may be made for the professional and technical components of services. The technical component is frequently billed by suppliers like independent diagnostic testing facilities and radiation treatment centers, while the professional component is billed by the physician or practitioner. Payments are based on the relative resources typically used to furnish the service. Relative value units or RVUs are applied to each service for work, practice expense, and malpractice expense. These RVUs become payment rates through the application of a conversion factor. Geographic adjusters, geographic practice cost index are also applied to the total RVUs to account for variation in practice cost by geographic area. Payment rates are calculated to include an overall payment update specified by statute. Calendar year 2023 Physician Fee Schedule Rate Setting and Conversion Factor. CMS is finalizing a series of standard technical proposals involving practice expense, including the implementation of the second year of the clinical labor pricing update. CMS also included a comment solicitation seeking public input as CMS develops a more consistent, predictable approach to incorporating new data in setting PFS rates. Per statutory requirements, CMS is also updating the data that CMS uses to develop the geographic practice cost indices or GPCIs and malpractice RVUs. With the budget neutrality adjustments which are required by law to ensure payment rates for individual services don't result in changes to estimated Medicare spending, the required statutory update to the conversion factor for calendar year 2023 of 0% and the expiration of the 3% supplemental increase to PFS payments for calendar year 2022, the final calendar year 2023 PFS conversion factor is $33.06, which is a decrease of $1.55 to the calendar year 2022 PFS conversion factor of $34.61. Evaluation and Management or E/M visits. As part of the ongoing updates to Evaluation and Management visit codes and related coding guidelines that are intended to reduce administrative burden, the AMA CPT editorial panel approved revised coding and updated guidelines for other evaluation and management visits effective January 1st of 2023. Similar to the approach CMS finalized in the calendar year 2021 Physician Fee Schedule Final Rule for office/outpatient evaluation and management visit coding and documentation, CMS finalized and adopted most of these AMA CPT changes in coding and documentation for other evaluation and management visits, which include hospital inpatient, hospital observation, emergency department, nursing facility, home or residence services, and cognitive impairment assessment effective January 1st of 2023. This revised coding and documentation framework includes CPT code definition changes, revisions to the other evaluation and management code descriptors including new descriptor times where relevant, revised interpretive guidelines for levels of medical decision making, choice of medical decision making or time to select code level except for a few families like emergency department visits and cognitive impairment assessment which are not timed services, eliminated use of history and exam to determine code level. Instead, there would be a requirement for a medically appropriate history and exam. CMS finalized the proposal to maintain the current billing policies that apply to the EMs while they consider potential revisions that might be necessary in future rulemaking. CMS also finalized creation of Medicare-specific coding for payment of other evaluation and management prolonged services, similar to what CMS adopted in calendar year 2021 for payment of office/outpatient prolonged services. These services will be reported with 3 separate Medicare-specific G codes. Split or shared evaluation and management visits. For calendar year 2023, CMS finalized a year-long delay of the split or shared visits policy CMS established in rulemaking for 2022. This policy determines which professionals should bill for a shared visit by defining the substantive portion of the service as more than half of the total time. Therefore, for calendar year 2023 as in calendar year 2022, the substantive portion of a visit is comprised of any of the following elements: history, performing a physical exam, medical decision making, spending time more than half of the total time spent by the practitioner who bills the visit. As finalized, clinicians who furnish split or shared visits will continue to have a choice of history or physical exam or medical decision making or more than half of the total practitioner time spent to define the substantive portion instead of using total time to determine the substantive portion until calendar year 2024. Telehealth services. For calendar year 2023, CMS is finalizing a number of policies related to Medicare telehealth services, including making several services that are temporarily available as telehealth services for the public health emergency available at least through calendar year 2023 in order to allow additional time for the collection of data that may support their inclusion as permanent additions to the Medicare telehealth services list. CMS finalized their proposal to extend the duration of time that services are temporarily included on the telehealth services list during the public health emergency for at least a period of 151 days following the end of the public health emergency in alignment with the Consolidated Appropriations Act of 2022. CMS confirmed their intention to implement the telehealth provisions in Sections 301 through 305 of the Consolidated Appropriations Act of 2022 via program instruction or other sub-regulatory guidance to ensure a smooth transition after the end of the public health emergency. These policies, such as allowing telehealth services to be furnished in any geographic area and in any originating site setting, including the beneficiary's home, allowing certain services to be furnished via audio-only telecommunication systems, and allowing physical therapists, occupational therapists, speech-language pathologists, and audiologists to furnish telehealth services will remain in place during the public health emergency for 151 days after the public health emergency ends. The Consolidated Appropriations Act of 2022 also delays the in-person visit requirements for mental health services furnished via telehealth until 152 days after the end of the public health emergency. CMS finalized the proposal to allow physicians and practitioners to continue to bill with a place of service or POS indicator that would have been reported had the service been furnished in person. These claims will require the modifier 95 to identify them as services furnished as telehealth services. Claims can continue to be billed with the place of service code that would be used if the telehealth service had been furnished in person through the later of the end of calendar year 2023 or end of the year in which the public health emergency ends. Behavioral health services. In light of the current needs among Medicare beneficiaries for improved access to behavioral health services, CMS has considered regulatory revisions that may make greater use of the services of behavioral health professionals, such as licensed professional counselors or LPCs and licensed marriage and family therapists or LMFTs. Therefore, CMS is finalizing the proposal to add an exception to the direct supervision requirement under their Incident to regulation at Title 42 Code of Federal Regulation 410.26 to allow behavioral health services to be provided under the general supervision of a physician or non-physician practitioner rather than under direct supervision when these services or supplies are furnished by auxiliary personnel such as LPCs and licensed marriage and family therapists incident to the services of a physician or non-physician practitioner. CMS is also clarifying that any service furnished primarily for the diagnosis and treatment of a mental health or substance use disorder can be furnished by auxiliary personnel under the general supervision of a physician or non-physician practitioner who is authorized to furnish and bill for services provided incident to their own professional services. CMS believes that this change will facilitate access and extend the reach of behavioral health services. Finally, CMS indicated in the final rule that they intend to address payment for new codes that describe caregiver behavioral management training in calendar year 2024 rulemaking. In calendar year 2017 and 2018 physician fee schedule rulemaking, CMS received comments that initiating visit services for behavioral health integration or BHI should include in-depth psychological evaluations delivered by a clinical psychologist and that CMS should consider allowing professionals who were not eligible to report the approved initiating visit codes to Medicare to serve as a primary hub for behavioral health integration services. Considering the increased needs for mental health services and feedback CMS has received, they are finalizing their proposal to create a new general behavioral health integration code describing a service personally performed by clinical psychologists or clinical social workers to account for monthly care integration where the mental health services furnished by a clinical psychologist or clinical social worker are serving as the focal point of care integration. CMS is also finalizing the proposal to allow a psychiatric diagnostic evaluation to serve as the initiating visit for the new general behavioral health integration service. This is it for today. Thank you for joining me. If you found this information useful, please consider subscribing to my channel and leave me a few comments. Hope to see you next time. Bye now.